So the screening is exactly the same, but since we did the first trial, let me give you what I talk to patients about. So, what I tell them, so in the first trial and in the responder HF, the new trial, it's still going to be the same echo, non-invasive screening, 6-minute walk test, BNP, et cetera. And then they come for invasive exercise hemodynamics. So here is how I plan to talk to the patients going into the next trial. I basically tell them that, look, there's 3 possibilities going into this invasive exercise hemodynamic test. So this is once they've passed the echo screening, I say, look, there's 3 things. Number 1, we might do this exercise test in the cath lab and you don't meet criteria for HFpEF. That's really important for us to know because we think you have HFpEF. This is showing that you don't have HFpEF. So we have to look for other causes of your shortness of breath. So this is really good because we're going to find out really if this is what's causing your shortness of breath. That's number 1. And if it's not, then we'll stop wasting time on HFpEF and go to something else like lung or other issues. Second thing is if you do qualify and you do have HFpEF, which we think you do, most likely you will, then either you meet the criteria where you go into the trial, great, it's still sham controlled, but eventually you'll be able to, cross over, or we find out that, for example, the blood vessels in your lungs are diseased. And this is also good news for you and for us because we found in the prior trial that if we were to give you the shunt device, you actually would do worse. You're more likely to be hospitalized for heart failure with the device. So we don't want to give it to you. And what we do here at Northwestern is I have a backup trial, a pharma trial. I always have a pharma trial going on so that if they don't qualify for reduced LAP, then I say, okay, sorry, you don't qualify, but hey, I've got this other trial for you. It's a pharma trial that we can try to get you into. And so they feel like, okay, at least there's another option for them, because they are, believe me, when patients don't qualify, they are very upset, because they've mentally prepared to get the device or sham or whatever. And so, it is something that, we try to help them with. The other thing when I talk to patients, I say, about the sham and the control, I say, look, if we don't do the trial, you have 0% chance of getting the device. If you do the trial and you meet the criteria, you have a 50-50 chance, which is better than 0 chance. So, sometimes that line of, talking to patients works. Sometimes it doesn't. It's, different by different patients. But that's how I go about doing it.